Aaron, let's ground this in adolescence. Identity formation is delicate, push hard in the wrong direction and you can break things you can't easily repair. Conversion therapy for minors, programs that try to change a kid's sexual orientation or gender identity, lands squarely in that danger zone. The best evidence links exposure to higher depression and suicidality. Even if the data are observational, the direction is consistent, the theory is plausible, and major professional bodies agree, don't do it. Caleb, I also oppose anything coercive or outcome-directed. But banning it is a legal instrument, and laws have edge cases. My concern is overbreadth. If a statute defines conversion therapy as any discussion that causes a child to question their current identity label, you've effectively banned exploratory psychotherapy. Adolescents bring ambivalence into therapy. Clinicians should be free to explore, reflect, and sometimes challenge. The law must be precise. Aaron, precision is fine. We can draw a bright line between directive change efforts and exploratory therapy. The former has a goal: you must become straight, you must desist, and typically uses techniques that pathologize identity. The latter is patient-led, tell me how you feel. What fits? What harms? Prohibitions can target the first category while explicitly protecting the second. The harm data we have are about the first category. Caleb, in practice, separating intent from effect is tricky. A clinician may believe they are exploring, but parents may hear affirmation as endorsement, or the youth may feel nudged either way. If statutes are complaint-driven without clear standards, you'll chill open conversation. Therapists will avoid complex cases for fear of discipline. That hurts the very kids we're trying to help. Aaron, then let's codify standards. Define prohibited conduct as outcome-directed attempts to change orientation or identity using methods designed for that end. Define permitted care as non-directive, supportive psychotherapy focused on distress, coping, family dynamics, and comorbidities. Require documentation of goals set by the youth, not imposed by clinician or parents. That structure protects speech that supports exploration and bans practices with a change mandate. Caleb, add due process and clarity, model informed consent forms, examples of prohibited scripts, and a safe harbor for evidence-based, neutral modalities, CBT for anxiety, family systems work, trauma therapy, when goals are symptom relief and well-being, not changing identity. I'd also want to carve out that forbids using the ban to punish religious counseling that simply teaches doctrine without claiming to change identity or pressuring minors into treatment. Aaron, I'm wary of a carve-out that swallows the rule. If the doctrine insists that the young person's identity is disordered and must change, that's conversion by another label. The test should be behavior, not branding. Are you attempting to change identity, or are you supporting the youth's well-being? If it's change, it falls under the ban. If it's support, listening, coping skills, acceptance, even if rooted in a faith framework, that should be lawful. Caleb, fair, behavioral test plus clear guidance. Next, causality. The harm studies rely on recalled exposure and cross-sectional associations. Vulnerable kids may be more likely to be sent to conversion efforts and more likely to struggle later, even without exposure. We should acknowledge that limitation and avoid overstating certainty. It argues for cautious, narrow bans, not sweeping ones, and for funding better research. Aaron, I'm happy to say observational. But public health decisions often act on strong, consistent signals plus biological plausibility. We don't demand randomized trials of secondhand smoke before restricting it around kids. Here, the mechanism, shame, rejection, internalized stigma, fits what we know about mental health. Combine that with professional consensus about lack of efficacy, and the ethical calculus for minors points to prohibition. Caleb, ethics also includes autonomy. Parents have interests in their child's upbringing, and mature minors have emerging autonomy. If a 15-year-old asks to explore sexual attraction reduction because of sincerely held beliefs, does a ban forbid any clinician from engaging that goal? I'd prefer the law to say, clinicians may not promise change or use outcome-directed techniques aimed at identity, they may explore conflicts, values, and coping without a change mandate. Aaron, that's exactly the protective compromise, no promised or intended identity change, yes to exploration and values work. The legal ban covers conduct, not thoughts. It says, don't try to change who the kid is. Help them process who they are. That still honors autonomy because it protects the youth's right to open-ended therapy that supports their mental health without imposing an identity outcome. Caleb, then we reach the implementation questions. Who enforces? Medical boards. Consumer protection agencies. Civil liability. I'd avoid criminal penalties. Prefer professional regulation with graduated responses, guidance, warning, suspension. Publish to identified case summaries, so clinicians learn from boundaries, not fear them. Aaron, agreed? Also pair the ban with access, fund-affirming services, especially in rural areas, telehealth coverage, training for school counselors, hotlines, family education to reduce rejection. A ban without capacity feels punitive. A ban with capacity is protective. Caleb, family systems matter. Many parents feel sidelined. Provide structured family sessions that help parents support their kid even when beliefs differ. Evidence shows that acceptance behaviors improve outcomes regardless of ideology. That reduces the pressure to seek conversion programs in the first place. Aaron, we also need to be mindful of how bans are messaged. The goal is not to score culture war points, it's to keep kids alive and well. Public guidance should emphasize, exploratory therapy is welcome, clinicians will not be punished for discussing identity, what's prohibited is promising to change identity or using practices designed to do so. Caleb, that messaging will decide whether clinicians stay engaged. If they hear anything you say about identity could be conversion, they'll self-censor. If they hear be non-directive, document goals, focus on well-being, they'll do what they're trained to do. Aaron, last mile, evaluation. Require sunset review with data, complaints, board actions, youth mental health metrics, service access. If outcomes aren't improving, recalibrate. If complaints show confusion at the boundary, refine guidance. Laws should learn. Caleb, then we converge, prohibit outcome-directed conversion efforts for minors, protect open-ended, patient-led therapy, regulate through professional boards, expand access to supportive care, give families tools to be protective even when struggling, and evaluate. Aaron, that's a package I'll stand behind. The bottom line is simple, kids deserve care that doesn't try to change who they are. Everything else is scaffolding to make that true in practice. Caleb, and the scaffolding matters, clarity, capacity, due process. Do those right, and we protect both youth and the integrity of therapy.